So as a follow-up of Shakta's wonderful talk on this modified monofocal, let's go on to the high-end multifocal intraocular lens where now we have access to. I'm going to be talking about the Synergy intraocular lens. By way of financial disclosure, I'm a consultant to both, relevant to this talk, I'm a consultant to both Johnson & Johnson and Alcon. I think I have always found that whenever we prescribe a pair of spectacles, whether it's to a 10-year-old getting his first myopic glasses, or a 42-year-old being given his reading glasses, or a 60-year-old who has just received a simple hydrophilic intraocular lens, we say you have to go ahead and wear glasses. There is a tinge of dissatisfaction. So if only we could address all these patients across all age groups to live independently without the relying on glasses, that would be a great way to go. And I think as surgeons of the third millennium, we owe it to our patients and ourselves to find ways and means of doing it. So my pal, myself, and several others, obviously Sartaj is a new entrant, have been talking about multifocals, have been using multifocals for a couple of decades. But then I think even today, our penetration as far as multifocals is concerned is just about 15%. And the torics being adapted more frequently. It's the cost is, of course, the concern, but then it's not just that. There is definitely a certain segment of population who want the very best, irrespective of the cost angle. And one of the things is often we have to make the patient pick and choose as to what they want. It's whether you want near vision to be good or intermediate or distance. Obviously, the other aspect is also life happens at all kinds of lighting conditions, bright light, dim light, ability to drive in the night without much of discomfort. When you tell the patient that your intermediate vision might be a little less, but you would be able to read quite well, you would be able to see at distance and reading, but obviously there might be glare and halos that you have to contend with. These are some things that you can tends to put the patient off and make them stick to a monofocal option. So obviously, if you had a lens which could take care of the visual needs for all distances, at distance, intermediate, and near, that would be a great way to go. Another important factor is that the arm span of the patients, when we talk about near vision being at 40 centimeters or at 60 intermediate vision being at 60 centimeters, that's not quite adequate. When we talk about most of the trifocals that are currently available, most often they are talking about near vision at 40 centimeters. But especially in our conditions where the people are built somewhat smaller in the Asia Pacific region, and the arm span is less, and 5.5 feet is the normal height of the individual, as well as the kind of calligraphy that we have, the kind of the Chinese letters as well as the Indian letters are obviously much more closer than the English language letters, the alphabets. So obviously the kind of near visual acuity that our patients need is much higher. And on a lens which offers them an ability to read well at 33 centimeters rather than 40 centimeters would be a great choice. I always considered is the paradox of the premium when we talk about premium intraocular lenses. I have been doing this for the last 15 to 20 years. When I go to a great restaurant and I want a wonderful meal to be enjoyed with my friends or family, what I'm looking for is a well-rounded experience. But if the chef walks up to me and says, "Sir, I'll give you a premium meal, but your soup might have a little extra salt. Your main course might be a little undercooked. Your sweet dish might be a little too sweet." Obviously, I'm going to ask, why are you charging me a bomb if there's going to be such compromises? I think we have been doing exactly that to our patients. We have been charging them significantly more for their multifocals or multifocal torics. But at the same time, compared to monofocals, which is a no-brainer, and both we and our counselors tell them you can straight away go for this lens, it would give you a good vision. We spend a considerable amount of chat time trying to explain to them and trying to make them accept and understand the kind of demerits that these lenses come with. So obviously it's a paradox of the premium, and if we going forward we have to adapt this in our highest numbers, we have to do away with this. As was said earlier, monofocal intraocular lenses are great lenses, And I think that's something which should give you excellent vision. It's a no first lens giving excellent vision for distance. But obviously for intermediate and near, the patient might need a more progressive lenses outside. Then multifocal intraocular lenses, which you have been using for quite some time, it gives you a good distance vision, good near vision, but there is a significant segment which is where the intermediate vision, where it's not quite adequate. And basically, as we know that more than near vision in our day-to-day life, intermediate vision is becoming more important. Is not looking at the tablets or looking at the laptops alone that's important, but it's also even for doing your shopping, doing your driving, when you have to look at the dials of your car, and even at cooking or sewing and threading. All these things, intermediate vision becomes quite important. So all kinds of patients, obviously, multifocal intraocular lenses come with a caveat that there might be an inadequate intermediate vision. Then we have the trifocal intraocular lenses. I believe most of us who are doing premium lenses are using these lenses, and I have a significant experience with them. And overall, it has been a great lens. But at the same time, there again, there are areas where the lens seems to be quite inadequate, especially when it comes to near vision at the distance of about 33 centimeters or so, where it seems to be quite inadequate. And something like a synergy, where you have a continuous range of vision, that's synonymous with synergy, where obviously there is a little drop off in between, but overall, right from infinity all the way to 33 centimeters, you have a reasonably good vision. That might be a good way to go. How does this, what exactly is the origin of the name synergy? It's because of a synthesis of the advantages of a true multifocal lens like the +4 ad Tecnis multifocal and the EDOF lenses, which occupied our practice almost for a couple of years in the period between 2017 and 19, before the trifocals came in. So essentially, one of the first multifocal lenses I was seriously using were the Tecnis +4 diopter lenses. And especially even today, if I have a 80-year-old who doesn't drive much, who doesn't go out much, but wants to look at the newspaper without relying on glasses, wants to have good distance visual acuity, it's a great lens. But the only problem is that the near vision is 25 centimeters. And of course, subsequently, the low ad multifocals came in with a 2.75 ad and the 3.25 ad. And you can mix and match these lenses or do a micro monovision, as we already discussed, to achieve the kind of visual acuity that these patients want once they are bilaterally implanted. The Symphony was a great lens. Basically, it gave us a good intermediate vision, but when it came to near vision, there was a drop-off. The Synergy is a lens which seems to synthesize the advantages of both the Symphony and the excellent near vision acuity that the true multifocal intraocular lenses offered, so that there is a continuous range of vision that these lenses offer. So as you can see here, you have the true diffractive multifocal lens here, the EDOF lens over here, and the combination of these two is essentially what the Synergy offers. Basically, the EDOF lens or the Symphony used to offer the HLA design of these lenses used to work very well for intermediate vision and for distance vision. In the case of Synergy, what the HLA design did for the intermediate vision is doing for the near vision, so that we are having a continuous range of vision from near to distance. Looking at the defocus curves, most of you would have seen these curves earlier also. What you see over here in the green might be what's ideal, where you have a logma visual acuity of 0 or better for distance. And when it comes to intermediate and near, you have it all the way in the region of 2020 or 2025, even when with a +3 ad, that is when the near vision is 33 centimeters. What we see with our conventional multifocal intraocular lenses is an excellent distance visual acuity and a reasonable, very good near visual acuity, but there is a significant drop over here where the intermediate vision is absent. And Basically, this peak over here would essentially depend upon what is the add power that is there in these lenses. Whether if it's a 4 diopters, it will be at 2.25 centimeters. If it has 3 diopters, it's at 33 centimeters. But then there is a significant area where the visual acuity is not good. Symphony, as I said, was a great lens. Again, it offered up to intermediate vision, up to about 60 centimeters. It offered good visual acuity, but subsequently there was a significant drop off, so that you had to mix and match or do a micro monovision with these lenses. What you get with the Synergy is something like this, where you have a peak for distance and all the way across right up to near visual acuity at 33 centimeters. You have a vision between 2020 and 2025. And that's the reason that the adaptability, the take of these lenses happens quite easily. We have done about an analysis of 64 eyes. We have implanted a lot more in recent times. And what we find is the mean defocus curve of these lenses is an excellent right up to from infinity, almost up to 33 centimeters. These patients seem to be able to give excellent visual acuity. The conversation on mini monovision, micro monovision, mix and match has almost disappeared today. We go ahead and implant lenses aiming at emmetropia in the first eye, never do a bilateral implantation, and then watch for the outcome in the eye, and go ahead, and we find that most often with the Synergy, we are able to implant to emmetropia. So that bilaterally implanted also, these patients work quite well. As I already mentioned, the Technis Synergy lens essentially has a proprietary diffractive design of the Synergy lens with a peak for distance and continuously distributed from distance to near. There's no areas, no lacunae from near to distance, and that's the reason that this proprietary SLA design is enabling these patients to see continuously all the way from near to distance. In the case of the Symphony, which preceded this was from intermediate to distance, but here you have all the way from near to distance. So this is again another representation of the same features: monofocal intraocular lens, precise focus for the far point. In the case of a multifocal lens, good vision for intermediate, but good vision for near and distance, but intermediate was somewhat deficient. In a case of a Technis Synergy, right from near to distance, you have a continuous vision that's available to these patients. The other important factors today, we all realize that it's not just the quantity of vision that's important, but the quality of vision is also extremely important. And MTF, for the modulation transfer function, is nothing but the comparison between the ratio of sharpness of the image. I'm putting it in a very simple words: the sharpness of the image of the object to the image of the image that's formed with the optical system. Any optical system, whether it's a natural eye or a camera lens or an intraocular lens, is going to cause a certain amount of degradation in the quality of the image compared to the quality of the object by means of contrast sensitivity. And what you find here is that Technis Synergy in photopic conditions performs slightly better than the other lenses, the other trifocal lenses that are commonly in use. But in scotopic conditions, when the pupils are dilated in a 5 millimeter pupil, the contrast sensitivity that you get with these lenses, the MTF, is almost twice as compared to the conventional the trifocal lenses that are in use today. This is another important slide as far as I'm concerned, and allows us to understand the performance of many of these lenses. And this is from a talk from I think it was not David Chang, but from I think I forget the person who delivered this talk, but an excellent talk. And what you find over here is that the conventional Technis monofocal intraocular lens, which is, I think, a gold standard lens as far as the performance of the lens is concerned, because you find that it has there is a certain amount of degradation in the quality of vision when the pupils extend from 3 millimeters to 5 millimeters. All you see here is that what is in light grays and for a 3 millimeter pupil, what you see in dark grays for the the scotopic pupil, when the pupils dilate to about 5 millimeters. The sensor, you can find that the degradation is quite significant because it doesn't have the asphericity incorporated in it, while the technique has the spherical aberration compensation that is over there. When you look at the Actisoft IQ, because of there is a certain amount of compensation for the spherical aberration, but the chromatic aberration is not completely addressed in these lenses. So what you find is that the performance of these lenses, as far as the MTF in scotopic conditions is concerned, is somewhat less. When you go over to the trifocal intraocular lenses, even with this photopic condition, it's somewhat less compared to the monofocal intraocular lenses. And when the pupils dilate, the amount of degradation is significantly less. And as you can see over here, the multifocality in in the case of a trifocal lens is sub 0.2 in almost all the commonly used trifocal intraocular lenses. Come to the EDOF intraocular lens, essentially a symphony intraocular lens, you find that the photopic and the scotopic, the degradation when the pupils dilate from 3 to 5 millimeters is significantly very, very minimal. And you find that it's almost comparable to what you get with a monofocal intraocular lens. So essentially, you get something as far as intermediate vision is concerned, but there's no degradation of the quality vision compared to a monofocal intraocular lenses. And that has been the selling point for the EDOF Symphony for a long time. When you come to synergy, compared to the EDOF, there is a mild degradation. Instead of 0.44, it drops down to 0.34. In this particular chart, it shows as if in the mesopic conditions, it slightly improves, but that might be not true. But essentially, between the photopic, a 3 millimeter pupil and a 5 millimeter pupil, the synergy gives excellent quantity of vision without a commensurate drop in the quality of vision. I think that's the reason why we prefer these lenses. We all know about the importance of correcting spherical aberration. I think what we are doing today is also correct chromatic aberration with both the symphony and the synergy. And both these correction of the Q value of this almost the entire Technis platform lenses is minus 0.27, and the average Q value of a normal human cornea is about plus 0.27. They almost tend to compensate it completely, and also it has the ability to correct chromatic aberration because of the Abbe number and also because of the features which I'll be dealing with subsequently. And when you are correcting both the spherical aberration and the chromatic aberration, is not just additive, but they seem to work in synergy with each other, potentiate each other, and because of which the quality of vision when you get with any kind of Technis lens and with especially a synergy is quite significantly higher. It more than compensate whatever degradation that would happen because of the multifocality that's incorporated in it. We all understand spherical aberration, but chromatic aberration is something which is still a new kid off the block, but we are beginning to understand it. We also realize that with the chromaline technology that is incorporated in the Symphony and the Synergy, we are able to reduce the chromatic aberration also significantly. What exactly is it? In all the normal human eye has a positive chromatic aberration. Because of that, the blue light is brought in front, focus in front, when the green light is exactly in focus on the fovea, and the red light is brought in focus behind. And this spread of focus can extend almost up to 1.38 diopters or thereabouts. But when you implant a conventional lens, which does not have a ability to compensate for chromatic aberration, that again comes with a positive chromatic aberration, because of which it increases the amount of chromatic aberration that's inherent in the cornea. And thus, once you implant these lenses, the amount of spread of this significantly enhances to almost 2 diopters, degrading the quality of vision. When you go ahead and implant a lens with the chromaline technology like the Symphony or Synergy, which comes with a minus chromatic aberration, it tends to compensate, not completely neutralize, but compensate for the inherent corneal chromatic aberration, and because of which the spread is considerably less compared to the other conventional lenses. And that's the reason that the quality of vision is much better. And especially added on to the spherical aberration that we already alluded to, it significantly enhances it. This is another way of depicting this. What you see, the dotted line, is the kind of chromatic aberration that the patient would have subsequent if the patient was left aphakic. When you add on one of the trifocal lenses that are commonly used and that are quite popular, what you find is the chromatic aberration is significantly increased compared to an aphakic condition, simply because these all have a positive chromatic aberration. That's also the case with the Technis multifocal, though to a lesser extent, because it doesn't have a chromaline technology. But when you talk about the Technis Symphony or the Technis Synergy, because they have a negative chromatic aberration, they tend to reduce the amount of chromatic aberration compared to what would have the patient would have been dealt with if it had been left aphakic, and that's obviously a significant advantage. The other important feature of the Synergy has been that it has a violet blocking technology. We all are aware of the UV blocking technology, where up to 400 microns is blocked off. Almost all intraocular lenses that are manufactured today have the UV blocking technology incorporated in them. The blue blocker, which has also been commonly in use, has been around for many years, blocks off up to 480 microns. That is, it blocks both, both the UV light as well as the blue light as well as the violet light. It has been found that it's the violet light, which is 400 to 440 nanometers, which is the shorter wavelengths of the light, which creates a significant amount of scatter and causes degradation of the quality of vision. But the blue light, which is between 440 to 480 nanometers, is important for the circadian rhythm, for scotopic vision, improves the quality of vision. When you block off the blue light, maybe there is a price to pay by way of compromise in the quality of vision. So if you can block off the more deleterious the UV light and the violet light, but allow the blue light to pass through, that would be a significant advantage. And especially with the LED technology gaining ground in very rapidly, the blocking off the violet light becomes more and more important. And that's exactly what the Synergy is able to deliver. And that's one more advantage as far as these lenses is concerned. So essentially, just like the eye hands that Sataj talked about, there's really, if you're used to using the Technis intraocular lenses, then the Synergy is something, again, you can easily adapt. It has 15 rings on it, and it's a full diffractive lens. That's again a major value addition in these lenses, because of which the patient, irrespective of the lighting conditions, get the advantage of a near vision. And this is the intraocular lens, which has been implanted in the eye. It can go through a 2.2 millimeter incision, though my temporal clear corneal incision is usually 2.4 millimeters. You also see that the central disc is somewhat larger, because of which even in small pupils, the patients have a reasonably good visual acuity. So before, just like for any multifocal intraocular lenses, mind you, we are not saying that the Synergy doesn't have dysphotopsia. Definitely, this is a conversation that you need to talk to about your patients. And that's the reason there's a role for a lens like eye hands still in the marketplace. So there is splitting of light even with these lenses. So dysphotopsia enters into the conversation. Our preoperative evaluation and counseling is no different for these lenses compared to what we were doing with our earlier multifocal intraocular lenses. We do a comprehensive eye examination, use usually IOL Master 700. The LensStar also does a good job. There are several excellent other ocular biometers, but we used to, the go-to formula is not the Barrett Universal 2, but the Barrett TK toric formula, which tells us whether the patient requires a toric intraocular lens or not. If the patient has a significant toricity, even at T3 or a 1 or 1.25 diopters, especially if it's against the rule astigmatism, we completely sway away from the Synergy or the eye hand, simply because if you implant a multifocal lens, even a Synergy, without taking care of the cylinder, then that's not going to work too well. I think the Synergy toric is already available. The eye hands toric is also available. And we are looking forward to it becoming available in the Indian market also. And I'm told it's going to happen quite soon. So obviously that would increase the uptake of these lenses. Looking at the ocular surface, the OCT macula, the eye trace for extreme degrees of higher order aberrations is important. Angle alpha, we used to talk about it, but we do not give much importance to it. Looking at the higher order aberrations becomes especially important when a patient who has undergone prior refractive surgery, like a well-performed laser vision comes to you and looking for freedom from glasses. We were initially thinking that it's a strict no-no as far as my implanting multifocal implants is in these conditions concerned. But today, we started implanting the Symphony earlier, and today, if the patient had excellent visual acuity post refractive surgery and had a small amount of refractive error corrected on his eye, and I find a sea of green on the topography with very little of higher order aberration, very little of coma trefoil, with a significant conversation, I would not hesitate to go ahead and offer a synergy also in these cases. So what exactly is synergy bringing onto the table for us? There are several other excellent platforms. Is the freedom of choice that we have today to pick and choose the best lens that's suitable for each patient. So this gives us continuous range of vision from 33 centimeters to distant visual acuity for all lighting conditions, corrects spherical aberration, corrects chromatic aberration with potentiate each other, and that gives us a better contrast and quality of vision. Because it's a full 6 millimeter diffractive optics, it's a pupil independent design. There's a UV and violet blocking, and most importantly, it's based on the tried and tested Technics platform, which I think more than 1 million of these lenses, or is it 2 million? I forget, of these lenses have been used, and all the proven advantages the Technics platform is added on to the features that I already mentioned. I think this is so. I believe cataract is something just comes in. We are also using these lenses of prelex. I think you don't stop having fun when you get old, but you get old when you stop having fun. So 60, 70 is just a phase in your life, and you just have to go ahead, exchange your lenses, and enjoy life of a 20-year-old. So life begins at 60 centimeters, 60 at the age of 60, and maybe at 33 centimeters. So maybe synergy is a good choice to have. Thank you so much for your kind attention.
Thank you very